Right, so I'm meant to be talking about how to explain TTP to friends and relatives. It's great there's a leaflet for the employers as well, because that is a big issue, isn't it? But in order to, I guess, understand what or appreciate how to explain it, I'm going to do a refresher of what it is for you as well, if that's okay. I apologise to those who were here 2 years ago, because it's a lot of similar slides, so it's more of a revision for you. But if you've not seen it before, hopefully you'll find it helpful. So I guess one of the questions, what is TTP? And it really does depend who you ask. So if you ask a haematologist, what is TTP? They ought to know what TTP is. Haematologists ought to know. And it is something that scares haematologists, okay, because it's always an emergency situation. But haematologists know how to deal with it. But, and you may have found this out, if you ask anyone who isn't a haematologist, they probably have never heard of it. So you think doctors should know about all the diseases that people get? They don't, especially diseases that affect 1 in every million people. And it's so rare that people just don't necessarily know about it. And so you have to not only explain to your friends and relatives, but sometimes you have to explain to healthcare professionals and doctors what your condition is. And that's because there are so many things that we have to know. We can't just know everything. So you have to be patient with us, if that's okay. So yeah, not everybody knows. This is just this on the street I live in, up the road. So when I first saw it, I thought you'd been doing graffiti to spread the word, but it's actually a terrorist group. Okay, so other people do unfortunately use the same acronym as well, so just be careful. So how does it present? And you'll know this. The symptoms can be, and everyone has a different journey. Every patient has a different journey. And you'll be hearing from people after me, which is really good. And sometimes it can be really vague, just not quite right, maybe just on and off confusion, a bit of bruising, just abdominal pain, just really very, very different. We used to think that it was always a sudden onset thing. You go bang to being ill, but it's not necessarily the case. I think we're learning over time that it can sometimes be a slower process. But on the whole, it's always going to be relatively sudden. It's going to be relatively shocking to you and your family. There's not other conditions, other medical conditions. Often there's a workup, there's investigations, and there's a journey where you can start to appreciate what's happening rather than it just being bang like that. Also, when someone comes in, the key thing is that although the symptoms can be really vague, we just want whoever sees you to basically do what we call a full blood count. Take your blood. And what we do in a full blood count, we look at red blood cells, and we look at white blood cells, and we look at platelets. And this is where we look at the blood under the microscope. It's called a blood film. So what we want is someone comes in and someone takes a full blood count, someone makes the film, and one of us will have a look at it. And we want that to happen really quickly. And this film isn't normal, okay? So these are red cells, and they're meant to be like that, nice and round, and they are definitely not meant to be like that. Like a chunk, like we call it a fragment. It's a red cell fragment, and that's what we're looking for in TTPs, red cell fragments. Also, we like to see lots of these. I don't know if you see this little dot there. I don't know if you see that, that's a platelet. And we normally see a lot of platelets in the background, and there's only 2 here. So the platelet count is also low. That's a white blood cell, so you can ignore that, that's fine. So low platelets and fragments. So that's how we will start the process of wanting to make the diagnosis when we see this. I will go back in terms of history, okay, just so you understand how TTP, it really took 100 years for us to actually understand what TTP was, but I'll take you through that 100 years very quickly. So 1924, so yep, 101 years ago, the first description. So TTP has always been with us since the beginning of time. But if you go back, the first time it was described in a way we go, yep, that was definitely TTP. It was 100 years ago, and it was in a young girl, and had the fragments on the blood film and the symptoms that you would expect as well. But they had no test then to prove it, but it clearly was TTP. And really for the next 60 years after that, although people understood, and they called it Moshkevich syndrome, because they used to name diseases after people, but in the day, we don't do that anymore, actually. We don't name diseases after people. It's sort of an old-fashioned thing. But so for the next 60 years, really, people knew about it. They knew it was rare, but they didn't know what caused it. So what's the next step? And the next thing, the bit of the jigsaw that we got to understand what TTP was, it was observed in the 80s that there were the abnormalities of something called von Willebrand protein. So just to explain what that is, so it's one of your clotting proteins. So if you cut yourself, the von Willebrand protein helps stop you bleeding. And it opens up in the bloodstream into these long strings. And I call them sticky strings. So if you're going to explain to someone, if you ever go into this detail, about what's going on, in our bodies, we make these sticky strings, von Willebrands. We can just call them sticky strings. And they help our blood to clot. We need the sticky strings, but we don't want them to be too long and too sticky. And it was recognized in TTP that the strings were too long and too sticky. There was definitely a problem here, but we didn't know why our strings were too long and too sticky. So move on to 1991. Okay, it was shown that plasma exchange seemed to help in a massive way compared to the treatments that we had before that, and it was really game-changing, plasma exchange. How would you describe plasma exchange to another person? I would call it blood washing. We're taking out a person's plasma, and we knew there's something in there that wasn't right, and we replace it with fresh replacement plasma. So blood washing is probably the easiest way to describe it. It's a bit like dialysis, as you know, but it's not dialysis. So I would call it blood washing. So we knew there were sticky strings, but we didn't know why. We knew that blood washing seemed to help, but we didn't know exactly why. And then the sort of 90s to 2000, really exciting times, people like myself who were interested in TTP, because the final piece of the jigsaw. So it was realized that there was something missing in the blood, a deficiency of something. And they worked out ultimately from genetic testing of some families that the missing thing was ADAMTS 13, basically. ADAMTS 13, and I'm going to show you a little video of how ADAMTS 13 works, hopefully it'll work. And that was the final piece of the jigsaw to explain TTP, the missing ADAMTS 13. So, to explain what TTP is, I'll show you this video. Hopefully it will work. You may have seen it before. Is it on the website? It's very fancy because it was paid for by one of the drug companies. Only they have the money for this sort of thing. So if you injure yourself, those sticky strings, you can see the strings, capture platelets. That's what you want. You want to cover the hole, the blockage. But you also need this ADAMTS 13, and it's like scissors, and it snips these long strings, because if you have too many long strings, you capture too many platelets, and then the clots go all over your body. You want clots just where you need them, where you cut yourself. So the ADAMTS 13 is like this little scissory thing that cuts away the strings. But you can make antibodies against it. Like your immune system thinks, what is this ADAMTS 13? I'm going to destroy it. And it's autoimmunity. You're attacking your own ADAMTS 13 with these antibodies that you made. Rarely can also be born with it. I'll mention that in a minute. So then you've got these long strings. They're not being cut up. You're making too many platelet. The platelet is grabbing the platelets, these sticky strings, too many, and they're flying off and getting stuck in all the little blood vessels everywhere. And also the red cells are getting cut as they cross this area. So that's the fragments of red cells. They're being spliced as they go through these little clots. And the little clots sort of distribute all around the body, and the references for the thing. So most people with TTP, it is an antibody. Out of 100 people, the red is inherited. So rarely you can be born with the genetic problem that you can't make the ADAMTS 13. And you don't necessarily present when you're a child. You can present in adult, often in pregnancy. So the minority of people, it's a genetic problem, but for the majority, it's an immune problem where they've made that antibody that's destroyed the ADAMTS 13. The ADAMTS 13 can't cut the long strings, and so hence you get the TTP. hopefully this is making sense. It makes sense to me, but then hopefully it makes sense to you. So what are we doing when we treat people? We're replacing the missing ADAMTS13 and we're getting rid of the bad antibodies. If you've got the inherited one, we're only replacing the missing ADAMTS13. But if you've got the inherited, the acquired form, the antibody form, the two things we have to do is replace the missing ADAMTS13 and getting rid of those bad antibodies as well. And number one, number two, it's sort of almost in that order really. There is something else we have as available as well. It's not quite new now because we've had it for quite a few years. It's something called caplacizumab, so Capla. So even if you can't cut the strings, you can stop the strings grabbing the platelets. Because it's when the strings grab the platelets that is the problem. So you can block that. And it's called a nanobody. And it was originally derived from antibodies from llamas, I think. It's not, we don't get it from llamas. It's a copy of a llama antibody. It's made in a test tube. Okay, so you've not got llama in you. So it's very clever, and it stops the platelets attaching the strings, and therefore gives you, basically buys time. So before we've replaced your ADAMTS and before we've got rid of the antibodies, it's like it's a stepping, it's buying time to allow us to achieve those things really. So that's what Capla is, and you have to give it as an injection in the tummy or under the skin anywhere. And we usually send people home on it as well, because it usually takes a while to get rid of the bad antibodies. So I'm going to summarize. So we make sticky strings. We all make them to stop us bleeding, but we have to control the size of the strings with an enzyme called ADAMTS13 to balance things and make sure we don't clot too much. If we don't have enough ADAMTS13, the blood is too sticky. The platelets stick to the strings and block the blood vessels. This is dangerous because it can damage body organs, the little clots going into all the parts of the body. So to treat it, we replace the ADAMTS13. That's what plasma exchange does. We're putting in new plasma, we're putting in new ADAMTS13. And actually, we are on the cusp of potentially having what we call recombinant ADAMTS13 instead of plasma. We're using it already. So if you've got the inherited form, you may well be on an ADAMTS13 concentrate already, but we may be able to use it also for acquired as well instead of plasma exchange. That's the holy grail. We really hope, because plasma exchange is probably the worst thing that we do to people. Is to replace it with ADAMTS13, but you need to replace ADAMTS13. At the moment it's plasma exchange. And also, actually, plasma exchange does get rid of the bad antibodies as well, because the antibodies sit in the plasma. So it's got a dual effect of adding the ADAMTS13 and removing the antibodies. So it does have a value in that regard. So we're washing blood, we're getting rid of the antibodies, and then we also give some treatment to get rid of those bad antibodies. So we give steroids, we give something called rituximab, and we also, while those things are working, while those things are getting rid of the bad antibodies, we give you the Capla to just stop the process, buy time while that's working. So hopefully that does all make sort of sense. And I mean, they're interesting. I'm really interested to hear this from people. Is, when did you first, if you're the patient, when did you first understand what TTP was? Because at the time you come in, you're not really in a great state to understand it. And often it's the family that we're talking to first. Who explained it to you? When's the best time to go into the details of what it is? Is it better to have verbal, written, both? How could we as doctors do better? And it's been mentioned already, but one of the things we've noticed is obviously that with the age that people often are when they have TTP, they may have young children, and explain to them is particularly tricky. So a leaflet has been created. Holly started the ball rolling, and you guys have. I don't know if Holly's here. Is Holly here? Oh yeah, thanks Holly. There's a leaflet for younger children and older children, just to help with that sort of explaining process. And you've got copies over there and hopefully on the website. So that's, I think, really making progress in terms of improving the information that's available, and certainly thanks to TTP Network. And if you have any other ideas for, things that we need to do to improve communication, let us know. So with that, I'll Stop.
Do you want some answers to your questions?